Hello. Am I audible? Okay. So today we will discuss about the prescriptions in autonomic nervous system. So the different prescriptions are open angle glaucoma, Myasthenia Gravies, Organophosphorous poisoning, allergic rhinitis, benign prosthetic hypertrophy, and testing of refractory error, snake bite, as well as scorpion bite. So before going into the detail of this prescription, first of all, I would like to tell you that whichever the prescription you are going to write, you must know the format of the prescription, and very quickly I am telling you there is a superscription, inscription, subscription, transcription and signature. But here we will focus only the inscription, subscription and transcription part. Okay, we will discuss one by one each. I hope you all have gone through the relevant pharmacology of each topic. So first and foremost is the prescription for an wide open angle glaucoma. Glaucoma is of two types. It is an open angle glaucoma or angle closure glaucoma, in which there is a rise in the intraocular and many a times there may not be a rise also. Okay, previously it was thought that there is a definitely rise in the intraocular pressure, but many a times even though there is a not rise in the intraocular pressure, so the normal pressure glaucoma is also there, and it is characterized by optic nerve damage, visual field defects, and if it is not corrected it will lead to the irreversible changes. Now, as the name itself suggests, angle closure glaucoma. Generally, this prescription is not going to ask in your exam because it is an emergency condition, and in the angle closure glaucoma, there is an immediate need of the reduction in the intraocular tension. Okay, and the drugs, the life-saving drug is intravenous osmotic diuretic, that is mannitol. Okay, this is the life-saving drug. But here we are discussing about the open angle glaucoma and the prescription of it. Okay, but before that, which I am just give you some brief overview about. Here you can see there is a formation of aqueous humor from the ciliary epithelium and the ciliary body, and this aqueous humor passes through this anterior chamber, and there will be drainage of this aqueous humor mainly through this trabecular outflow, and some amount of the aqueous humor is drained through this uveosleural outflow. So when the pressure raises, obviously whenever there is a secretion of the intraocular fluid is more, or there is some problem in its drainage. So what are the possible target sites of the drugs? either you can reduce the formation of the aqueous humor, or you can increase the drainage, and mainly through the trabecular outflow, then the drug will be helpful if the drug acts on these target sites. And mainly the drugs that are available are beta blockers, mainly the timolol. Now how the timolol acts? Timolol acts by acting on this ciliary epithelium where the aqueous humor is produced, and it decreases, beta blocker decreases the secretion of aqueous humor. Then prostaglandin analogs, latanoprost and bimatoprost, it mainly acts by increasing the uveosleural outflow. Then the first and foremost drug that is discovered, that is cholinomimetics, pilocarpine. Now how this pilocarpine acts? Pilocarpine acts by contracting this ciliary muscle and the pupillary block. Here you can see the pupillary block. This pupillary block will be removed. That is the first one. And this will be mainly helpful. And because of this contraction of these pupillary muscles, it's somehow helpful to open up this iridocorneal angle. But in case of the open angle glaucoma, while pulling this scleral pore, this drug, it will be helpful to improving the patency of this trabecular meshwork. Okay, so this is how it will be helpful. Now alpha agonist, these drugs, they are mainly helpful by increasing the uveosleural outflow. Carbonic anhydrase inhibitors, you all know that it will not provide the bicarbonate ion, so the aqueous humor is not produced. And as I have told you, mannitol, it will be mainly useful in the emergency cases. Okay, so now I will directly jump onto the drugs which can be used. So previously, I will not go into the detail of these, but the two most promising agents are, one is the beta blockers, either this is timolol 0.25% or 0.5%. Okay, these are used. Now the equally efficacious drugs are prostaglandin analogs. These are latanoprost or bimatoprost. These are also equally effective. Now if you have to select between these two, there are both advantages and disadvantages of these groups. First we focus on the beta blockers. Their advantages is they are equally efficacious to that of prostaglandin analogs. These are the quite cheaper agent as compared to the prostaglandin analogs, but the problem is that even though you are selecting the lipophilic agent, so which crosses the cornea effectively, and you have to select the agent which is not having a local anesthetic agent, a local anesthetic action, that is very required, because otherwise it will cause hypoesthesia. Okay, so even though you are selecting this agent, but some amount of the drug enters into the systemic circulation and produces systemic adverse effects. And you all know that beta blockers should not be given in the patients having COPD or cardiac disease or other respiratory illnesses, diabetes, all that. Fine. And to prevent this, one has to press the inner canthus of the eye for 5 minutes after instilling the beta blockers. The another drawback with the beta blocker is you have to instill 3 to 4 times a day. There are no other major drawback of the beta blocker. Now as compared to the beta blocker, the prostaglandin analogs, they are equally efficacious. Hyperemia, permanent darkening of the iris and the eyebrow color, and increased eyelash growth. All these are there, but other systemic adverse effects are not there. But their biggest limitation is they are quite costly. If you compare the cost of the latanoprost versus timolol, this latanoprost is 10 times, roughly 10 times more costlier than the timolol. Okay, so you have to select between these two groups. Then the other drugs, they are used mainly when these drugs are not helpful or they are contraindicated as an adjuvant therapy. Okay. So now if we focus on the prescription, and the prescription should be either timolol 0.25% eye drops, one drop to be instilled in each eye every 12 hourly. You can write alternate beta blocker also, and patient education regarding the pressing the inner canthus and the follow-up after 10 to 15 days. You can alternatively write the latanoprost also. Fine. Then the next disease is the Myasthenia gravis. Now, Myasthenia gravis, as you all know, it is an autoimmune condition which is characterized by development of the antibodies against the receptor which are present on the neuromuscular junction muscle end plate. And because of this, there is a significant muscular weakness, and later on there is a paralysis also. Now, how you can treat this condition? You just think. Now, the treatment, it can be possible if you are giving the drugs which improving the function of the survival receptors and the receptor mediated action, or the mainly these antibodies, they are produced by the thymus, so thymectomy, it is the last resort. And here, yes, here you can see, if you can see the blue one, these are the antibodies. These are produced against the receptors. Okay. Now, this we have already discussed. Now, what is required? You required the effective functioning of the remaining receptor, and this can be possible with the help of the cholinomimetic agents, that is neostigmine and its congeners. Okay, neostigmine is having an added advantage also. It increases the release of the acetylcholine, which each nerve impulse, it can directly stimulate the cholinomimetic receptor also. But the limitation is that it is not targeting the main disease etiology. Okay, and that's why over a period of the time this is also not going to be helpful, but we are not having any other option. Another alternative is pyridostigmine. The only advantage is its frequency of administration is somewhat less. Okay, so either you give neostigmine 15 milligrams 6 hourly, or you give pyridostigmine. Fine. Now, as it is an autoimmune disease, you can give corticosteroids also. Okay, you can give the prednisolone, and there are certain principles of the using the corticosteroids. Initially, you give a high dose to induce the remission, and then you gradually tapering the dose. You can also give other immunosuppressants also. Plasmapheresis is also helpful. But if the prescription is asked, you have to write either pyridostigmine or you have to write either neostigmine or pyridostigmine. At most, you can write tablet prednisolone, a steroid, but it's my advice is to write only at your level either neostigmine or pyridostigmine. Okay. Then the next is organophosphorus poisoning. Now, organophosphorus compounds, these are the highly lipid soluble compounds, and these are used as an insecticide. You all know that. And the most common poison encountered in our emergency department, that is organophosphorus poisoning. They are the irreversible cholinesterase, and that's why what will happen, that whenever there is a toxicity of the organophosphorus compound, there is an irreversible inhibition of the cholinesterase enzyme, and that's why the acetylcholine is not going to be degraded, and that's why in all over the body, the symptoms are because of the excessive cholinergic overactivity. And what you can do? You can block or inhibit this cholinergic overactivity with the help of the anticholinergic agent, that is atropine. And second, where the problem lies is this, the you have to reactivate this enzyme. Okay, as you have to reactivate the enzyme, and this can be possible with the help of the enzymes. Okay, and you must not forget the principles of the emergency condition. So stabilization of the patient, termination of the exposure, or 100% humidified. Always right. Here I have written incorrect. You note down the 100% humidified oxygen inhalation. Then first and foremost obviously will be the stabilization of the vital parameters, termination of the exposure. But the drugs, whenever the drugs comes, you have to first write the injection atropine sulfate. You all know that it is available as a 0.6 milligram per ml, and this 2 ml ampule available, and you have to repeatedly give, because this is a very short acting drug, and organophosphorus, they are highly lipid soluble. They remain in our body for a very long period of the time. Many a times the requirement of the atropine for more than a week or a month also. Okay, and the continuous watch on the patient is essential, and you have to give this atropine 2 milligram intravenous repeatedly every 10 minutes till the signs of the atropinization. Now this can be asked in your viva that what are the signs of the atropinization. Then you will say that's a dryness of the mouth, but this is again a subjective. Then you will say that's a pupillary dilatation, so bilaterally dilated non-reactive pupil, but again it is a subjective. But the one most important objective sign is the tachycardia. So when the pulse rate raises more than 120, then it's a sign of full atropinization. Then after atropine only, you have to give this oximes. Okay, so injection prelidoxime or obidoxime. So this is the prescription of the organophosphorus poisoning. The next is the allergic rhinitis. Now as you just think, this is the condition, as the name itself suggests, it is an allergic condition. Okay, and it is an inflammatory disorder of the upper respiratory tract, and the allergic component is there, and that's why there is a role. One is the antihistaminic, and again in the antihistaminic you are having two choices. One is the traditional older sedative antihistaminic, and second is the second generation non-sedative antihistaminic. So out of these two you have to select the second one, and you may add the decongestant agent. Okay, but this decongestant may be used for a very short period. Primarily the antihistaminic should be given. So the selected agent should be among the antihistaminic, that is levocetirizine, and it is better to use the topical decongestant, that is gylometazoline. Okay, so the prescription should be the tablet levocetirizine 5 milligram. Okay, it's for 5 days, and xylometazoline nasal drops as and when required. When the patient is having an intolerable nasal congestion, in this condition you can give. And the other advice, patient education, this is the saline gargle, steam inhalation. Okay, but many a times the students write the patient education first. No, it should be written at the last. And again, now there is a rule from the government that you have to write the name of the drug in a generic name and in the capital letter, like we have mentioned in this slide. Okay, then snake bite. There are more than 200 species of snakes in the India. Majority of these are non-poisonous, but the most commonly poisonous species are the Indian cobra, Russell's viper, Soscal's viper, and Indian crate. And obviously, in addition to the other measures like reassurance, control the anxiety, immobilization of the part, splinting of the limb, and all that. The treatment is the anti-snake venom serum. Okay, this is an picture of the anti-snake venom serum. Okay, and there are chances of the reaction. Okay, so at the same time you have to keep it available, the steroids and the antihistaminics and adrenaline. Okay, so ideally one should initially test, you have to give the test dose, and if the reaction will not occur within a stipulated time, then we have to give an anti-snake venom serum. But as I have told you that it is an emergency condition, and if you can't wait for more, then you can directly give it, but with this precaution. Okay, and then the next come is the cobra bite. In this cobra bite, as I have told you, the injection polyvalent anti-snake venom serum. Yes. One important point here is that there are chances of muscular paralysis is also there, and this can be counteracted with the help of the reversible cholinesterase inhibitor. This is injection neostigmine. But if you are just giving this cholinomimetic agent for the reversal of this muscular paralysis, but at the fine. So mainly the injection polyvalent anti-snake venom serum. Again, you have to give it. This is very important. You go through the slide. It is reconstituted in 10 ml of distilled water and inject 20 to 40 ml IV very slowly at the rate of 0.5 ml per minute. Okay. Then the scorpion bite. Here I will tell you, obviously the anti-scorpion serum, it will be required. Other additional measures are required, but the biggest problem is there is a significant peripheral vasoconstriction is there, and this must be taken care of, and that's why alpha blocker, selective alpha 1 blocker, this I have shown in a red font. It makes a difference between life and death. So this is the first, and the second is injection anti-scorpion venom serum. Other supportive measures are obviously there, but again I am repeating, in scorpion bite the biggest problem is the significant peripheral vasoconstriction. This can be helped with the alpha blocker. Okay. Then yes, benign prosthetic hypertrophy. Now this benign prosthetic hypertrophy, as the name itself suggests, there is an enlargement of the prostate, and this prostate, it will affect the urinary outflow. There is a blockage or hindrance in the urinary outflow, and because of this there are symptoms of urinary hesitancy, retention, and all that. So, and this is a common condition. Obviously it is a condition seen in male after the 65 years of the age, and you have to give the symptomatic relief to the patient also, and at the same time you have to treat the disease also. Now, how the symptomatic relief can be produced? If you remove this blockage for the urinary outflow, now how you can remove it? By relaxing the sphincter which is present on the bladder trigone. Okay, and on that the receptors that are present are alpha 1A receptor. So if you block that receptor with the help of the alpha blocker, your immediate problem will be solved. But at the same time, the main problem is due to the prostatic enlargement. So you have to work on that also simultaneously. And that's why when you go through the textbook, it has been written that there are two components in the benign prostatic hypertrophy, that there is a one static component and one dynamic component. Static means there is a continuously increase in the size of the prostate you have to target. That also, there is one another dynamic component, that is you have to work on the tone of the bladder neck and the sphincter also. This can be the dynamic component, it can be targeted with the help of the selective alpha 1A blocker, and the static component, it can be targeted with the help of the 5-alpha reductase inhibitor, which will arrest or reduce the growth of the prostatic size. Now dear friends, you have to remember that the immediate relief is because of the alpha 1 blocker, because there is an immediate relief in the dynamic component. But at the same time, you simultaneously start the 5-alpha reductase inhibitor. Over a period of the time, there is a gradual reduction in the size of the prostate. Now again in the alpha 1 blocker, we have to select the alpha 1 receptors that are present on the bladder neck, prostatic capsule and prostatic urethra. And these are the alpha 1A. And these are known as a uroselective alpha blocker. These are tamsulosin, alpujosin and all that. And that's why the prescription should be tablet tamsulosin. You can also write prazosin, no issue, but better is tamsulosin. 1 tablet to be taken for 15 days and tablet finasteride also. Fine. But whenever you are prescribing prazosin or any other alpha blocker, you have to advise the patient that take the drug at a bedtime, when the patient is sitting in a bed, and remain in bed for at least 1 hour after taking the drug to prevent the occurrence of the first dose hypotension and subsequent damages. Okay. So now the next one is prescribe the mydriatic for testing the refractory error. So now here you want to check the refractory error. Okay. Now first to think that for testing the refractory error, what is required? There is a requirement of both the mydriasis as well as the cycloplegia. Now the mydriasis is achieved with both. It is with the sympathomimetic agent as well as with the anticholinergic agent. But if you want the mydriasis with cycloplegia, then you have to go for anticholinergic agent. Now whenever we are talking about the anticholinergic agent, the first agent that came in your mind is atropine. Why can't we use atropine? The reason is that atropine is having a slow onset of action and a very long duration of action, that this cycloplegia for around a month, we can't tolerate that. Okay. So we require an agent which is having a very rapid onset and a very short duration of action, and this agent is tropicamide. Okay, it is having an onset of action within 15 to 30 minutes and its action lasts for 4 to 6 hours also. So the tropicamide 1% eye drops, 1 drop to be instilled in eye 15 to 30 minutes before the testing the refractory error. Okay. So this is all about the prescription in the autonomic nervous system. We have discussed the benign prostatic hypertrophy, organophosphorus poisoning, the cobra bite, scorpion bite, testing the refractory error, glaucoma, and Myasthenia Gravies. Hope this will be useful to you. Now, it's my personal advice that you first go through the relevant part of the pharmacology, theoretical part of the pharmacology, then you go through the applied part of the pharmacology, then you go through that how you derive a particular drug for this condition. So it will be helpful also for selection of the P drug also. It will be also helpful for you to write a prescription also. Okay. Thank you. You can write your comments obviously in the chat box. Thank you. कही दे